So, like Nick said, my name is Nicole Ammon. I'm a licensed professional clinical counselor and the manager of integrated care initiatives at Neomed in the Department of Psychiatry. Um, so, we're going to talk about one of many possible topics in integrated care for coordinated specialty care within first episode psychosis today, and kind of coming back to but updating a talk that I've done before on sexual and reproductive health. So, in the past, I have talked about this, but it's an important facet of integrated care and something that we continue to come back to because it's kind of an under-discussed topic within the mental health world. But as a place to start out, the World Health Organization defines sexual health as a state of physical, emotional, mental, and social well-being in relation to sexuality. So it is not merely the absence of disease, dysfunction, or infirmity, and it requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences that are free of coercion, discrimination, and violence. So research indicates that individuals with serious mental illness, such as psychosis, have lower rates of being in long-term romantic relationships, including but not limited to marriage, and lower rates of sexual activity in the previous 3 months when surveyed. That said, for all humans, sexual satisfaction can play a key role in quality of life. Sexual intimacy is meaningful and can function as a buffer against chronic stress, depression, and suicidal ideation. And healthy romantic relationships have been shown to improve well-being kind of across the board. And access to sexual and reproductive health care is essential for all people. Assessing sexual health can give your healthcare team important information about a participant's health, well-being, and overall health goals. And studies continue to find that patients have unvoiced sexual health concerns that go unassessed. So in one study, it was anywhere from 22 to 42% of respondents reported experiencing a persistent sexual health concern in the last year, but only 8 to 15% of them reported actually talking with their provider about sexual health at all. And this is a particular issue for individuals with serious mental illness because they do tend to face a number of different types of disparities when it comes to sexual health. So the participants you work with potentially face these disparities. People with serious mental illness diagnoses have been found to be at an increased risk for engaging in higher risk sexual behaviors, putting them at a higher risk for sexually transmitted infections. Women with mental illness have similar pregnancy and parenthood rates to the general population, but at an increased risk of unplanned pregnancy, pregnancy complications, including miscarriage, worsening mental health symptoms both during and after pregnancy, and a greater potential for custody loss, in addition to having higher rates of abortion. People with serious mental illness are also less likely to access routine reproductive and sexual health care services. So things like getting access to protective contraception, accessing recommended preventive care and screening. For example, numerous studies have shown that women with schizophrenia have lower rates of screening for cervical cancer. And although there's some evidence that rates improve if a woman is more generally engaged with healthcare kind of as a whole, there's still lower rates of that screening. And although there's some evidence, although causality remains uncertain, exposure to prolactin elevating antipsychotic medications for a year or more has been associated with an increased odds of breast cancer in women with serious mental illness. So when prescribing things like antipsychotics, or when we know that a patient is taking antipsychotics, it's important to engage in a shared decision-making process that looks at individual risk factors for breast cancer in addition to kind of all of the other things that we're considering. And why do these disparities exist? Well, there are disproportionate rates of sexual assault, domestic violence, and victimization for individuals with serious mental illness. One of the most talked about reasons for sexual and reproductive health disparities is side effects of medications. This is at least one thing that some of our prescriber and nurse practitioner providers and nurse providers might more commonly ask about. But medications can cause more than just sexual side effects. They can also impact reproductive health. For example, in the literature, this can include infertility, which is already at a higher rate in individuals with serious mental illness than the general public. There can also be detrimental impacts on a fetus if a participant is taking medication during pregnancy. Other potential causes could be things that are like comorbid health and lifestyle factors like smoking, substance use, obesity, kind of your standard social drivers of health. And then health literacy can also impact sexual and reproductive health. And participants might have a poor perception or awareness of their overall risks. When looking specifically at sexual and reproductive health for young participant groups, the literature notes that adolescents and young adults in general experience a disproportionate burden of poor sexual and reproductive health outcomes. Sexual vulnerability at this stage is associated with initiation of sexual activity, relatively poor health literacy, and higher risk of sexual exploitation. A systematic scoping review of empirical studies and case reports focused on sexual and reproductive health issues in young people, and they determined young as ages 14 to 24 with psychotic disorders. There was about 52 case reports and 17 empirical studies, and most of those focused on sexual dysfunction that was kind of identified as common amongst this cohort and associated both with psychotic disorders themselves and antipsychotic medications. And while some forms of sexual dysfunction are attributed to the medications, it can be sexual dysfunction is experienced by a significant portion of young people with psychosis independent of the pharmacology. And there was a lack of interventional studies to manage the sexual risk-taking behaviors or STI risks in those with early psychosis. Lack of research on women's sexual health topics, including pregnancy or abortion, and very little existing work on gender-based violence, coercion, and issues around sexuality and gender. So a lot of work that needs to be done in this space. And April is Sexual Assault Awareness Month. Women and young people with mental illness are at elevated risks for sexual assault. A 2024 systematic review of 26 studies that looked at the years of from 1989 all the way up through 2020 across a range of countries and consistently showed a high prevalence of past year and adult lifetime sexual violence victimization across psychiatric service users, with higher rates found in women than men. So some of the newer studies that I looked at, one study noted that there was significant barriers to general sexual health care, including psychotic symptoms themselves. So something like paranoia or disorganization might hinder a participant's ability to trust professionals, engage in and arrange appointments with the appropriate providers, and engage in the care that's offered. While not explicitly described always as a barrier, some participants report prioritizing their mental health care above their kind of physical health needs. And as mental health providers, we have a tendency to do that too, prioritizing mental health symptoms and mental health needs and concerns over physical and sexual health needs and concerns. Mental health stigma has been particularly an issue, especially as it pertains to the decision whether or not to have children. And that becomes a barrier for discussing sexual health concerns, as was the discomfort of bringing it up and feeling like there's been a lack of solutions offered from providers when participants do bring up sexual health concerns. Several studies noted financial barriers to accessing things like HIV care and contraception. And it's important to note that healthcare providers and patients or participants often have different perception of what the actual needs are. And we, as kind of the clinical team, often perceive the needs of the participants we're working with based on our own clinical experience, our focus area, and how much time we spend with them, or in what setting or context we're getting to know them in. And we might miss a lot that's actually super important to them. So another study that I looked at was kind of a commentary. It was from Hughes in 2025. She noted that while some mental health clinicians avoid discussions of sexual and reproductive health due to discomfort and a lack of knowledge or training, a lot of clinicians aren't really sure what their role is, or should they, or how should they be having these discussions with participants. And they're concerned about potentially offending individuals or accidentally re-traumatizing those who have sexual abuse histories. And while avoidance of the discussion might be for well-intended reasons, her view is that it comes across as paternalistic and can be viewed as another way of silencing victims of sexual violence, kind of inadvertently replicating the patterns of abusers. And when discussions do happen, there can be sometimes kind of an air of or attitude of risk aversion and safeguarding, rather than openness and curiosity, with more of a focus on kind of that medical biological aspect of sexuality while missing the larger context of well-being. And this can lead to missed opportunities to connect folks to additional help or resources. And it certainly doesn't help us to address the known disparities in this area. And the health system has historically focused largely on kind of health outcomes, health risks, and harm reduction, as I started saying on the previous slide. So to think about a person's sexuality while only considering sexual and reproductive health is to miss a bigger portion of the picture. And one of the articles that I pulled from includes this image, and it suggests a reframing. Their focus was on public health, but I really think that this applies to mental health as well. But a reframing in a way that focuses on sexual well-being along with sexual health, sexual justice, and sexual pleasure. And they describe the interconnectedness of these four and their rationale for bringing distinct attention to sexual well-being along the other three pillars. And the authors note that outside of professional spheres, people rarely refer to sexual being per se, although the concept is kind of inferred through the idea that a sex life is supposed to be supposedly going good or well. That's, I guess supposed to mean there's some well-being there. But they point out that sexual well-being is a meaningful population indicator of overall well-being, and that incorporates outcomes that are increasingly recognized as important, but distinct from those kind of biomedical sexual health interventions. And they offer a number of definitions for sexual well-being, one being the cognitive and emotional evaluation of an individual's sexuality. Others that they know kind of extend to include satisfaction with sexual relationships and functioning, sexual awareness, sexual self-esteem, and body image esteem. And in operationalizing sexual well-being, the authors developed a model with 7 core domains. So sexual safety and security, respect, self-esteem, resilience in relation to past sexual experiences, forgiveness of past sexual experiences, self-determination in one's own sex life, and comfort with one's own sexuality. I'm not going to go into the details of the other pillars today. It's a pretty short article, and the link is in the references as well as hyperlinked on this slide. In case it's something that you want to check out, it should be something that you can access pretty easily, but if you need some help, just reach out and I will get access to the article for you. So the last thing that I'm going to talk about briefly today was kind of a neat intervention with direct relevance to coordinated specialty care. So I'll review that. And again, this is an article that if you need help accessing, I can absolutely post it in the iEcho. So the authors, and this was an article that came out of Toronto, so a Canadian mental health system, but they are also doing coordinated specialty care for early psychosis. And they note that youth with psychosis are at all the same risks as other youth and other individuals with serious mental illness. So they're at risk of having that inadequate sexual reproductive health information and not receiving the needed sexual and reproductive health care, setting them up for poor health outcomes. And in planning and development for an intervention in this area, they pulled together a research team, looked at some qualitative studies, and they found and identified some unique sexual and reproductive health and needs of women, transgender and gender diverse individuals with youth with psychosis and the barriers they face. So they wanted to develop an intervention around that. So what they did is they pulled together a working group, which was led by a psychiatrist and with clinical and research experience in reproductive mental health. They also had some youth advisors and youth engagement specialists who had lived experience of psychosis. They pulled in some sexual and reproductive health experts in the form of family physician and folks from Planned Parenthood, a registered nurse, a psychiatry resident, and a research analyst. The clinician members of this group said that they wanted to participate due to gaps in clinical care that they'd seen in this population, and the service users, those with lived experience, had expressed a desire to participate out of a place of healing and to advocate for more compassion. I'm getting a pop-up on my screen. To come out of a place for more compassion and care for others. So they were able to bring, everybody in this working group was able to bring their personal and clinical experiences to help create a focus on inclusion and intersectionality, trauma-informed care that had really leaned in on the importance of destigmatization and respect. And they note that this working group established values for their work, and these values included inclusivity, intersectionality, person-centered care, respectful reciprocal relationships, privacy, laughter, active listening, continuous mutual learning, sex positivity, destigmatization, and supporting client goals. And as you can see here, it was based on the Navigate model for coordinated specialty care. So they were able to kind of, their goal was to build this into kind of an existing framework. So they brainstormed goals and worksheets for each topic, along with clinician-facing and individual-facing, kind of participant-facing guidelines. And they based it off of the structure of the previous Navigate individual resiliency therapy modules, so those IRT modules. And they were careful to ensure evidence-based content while including affirming and youth-friendly lens and to the language and content. For each of the topics, for each topic, client-facing materials and clinician-facing materials were developed, so like check-in questions, potential topics, worksheets, goals, handouts, suggested agendas, all of those were developed. And the final module consisted of an introductory session, which consisted of an exploration of intersecting experiences and identities, and an overview of the module. And during that introductory session, 5 topics and subtopics were reviewed so that the individual could select those that were most important and those that they'd like to cover kind of in which order would meet their needs best. The materials were designed to be delivered across anywhere from 3 sessions up to 17 sessions, and the module is designed to be relevant and flexible across types of relationships, sexual orientations, and gender identities. Here's a bit more topic about kind of the subtopics that fall under the 5 topic areas. So the major topic areas being relationships, sexual health, reproductive health, sexual orientation, gender identity, and interpersonal violence. And each of them having different subtopics that participants could choose from based on what was most relevant and kind of highest priority need for them. They also considered topics for areas where clinicians might feel uncomfortable or ill-equipped, and they wanted to include strategies to mitigate this, including prompts for clinicians to examine their own assumptions and biases, to reflect on gaps in knowledge while encouraging additional learning and consultation with colleagues. They wanted to reiterate that in all of the materials, both clinician-facing and participant-facing, that the clinician you're working with might not be the expert in sexual and reproductive health, and that in order to get best care, you might need a referral out to somebody who is the expert in that. They also included a glossary of terms and prepared a resource sheet for clinicians to use throughout. So knowing that not everybody is going to feel super comfortable, they wanted to make sure that they were prepared across the board. And the goals for creating this were to improve knowledge of sexual and reproductive health, to improve communication and understanding about sexual and reproductive health goals, to improve confidence, empowerment, sexual function, and satisfaction, improve access to sexual and reproductive health care, which hopefully would reduce unplanned pregnancies and STIs, improve access to routine screening and engagement in routine screening, and improving perinatal outcomes as that would be applicable. And with the intentionality and foundation behind the process, I think speaks to this kind of a bigger perspective, because each of these objectives are important, but they also infuse the voice of the youth with lived experience of early psychosis into it. They expand the scope of the module into those 4 pillars that I mentioned earlier, so sexual health, pleasure, justice, and well-being. And the authors noted that employing a social justice orientation throughout all of this, and that it shows up in the module and content with a greater goal to reduce disparities for women and non-binary gender diverse youth with early psychosis, as well as planning for clinician self-reflection and growth. And the article kind of stops here, which is a little bit of a shame, but I'm going to be keeping my eye out for follow-up implementation and outcome studies. But in the meantime, I wonder if we can't just all take a page out of their book and try to implement some basic topics into our work with participants. So it's kind of food for thought, and I'll leave that on Nick and Crystal to digest how you do that. And I'll wrap up today, and there's lots of citations on the next couple slides, but here's some really cool resources that I think are useful for us individually, but also to point individuals to. The last resource, I literally just learned about it Tuesday, and it's very Alaska specific. It's iknowmine.org. And for those that live in Alaska, they actually will send out a bunch of free resources across a wide variety of topics, but it also has just a ton of information. So for the participants you're working with, it might just be a cool website that they can point to, to get some kind of very user-friendly resources. So something I thought I'd include. And I'm going to stop my share and mute myself.